Welcome to this session on achieving equitable access to primary care. I'm chairing this session and I'm Timo Sinero from Finland, Finnish Institute for Health and Welfare. We have about 30 minutes per each presentation, meaning the presentation is 12 to 30 minutes and then a couple of questions. First one, I suppose, is here, Donya Razavi, right?
Yeah.
Yes, and Canada, please.
Thank you. Good morning, everyone. Thank you for coming today. My name is Donya Razavi. I am what's called an OHT Impact Fellow. So if you've been at this conference, you must have heard about OHTs getting started in Ontario. And so it's a newly integrated model of care delivery within the Ontario province of Canada. By my name, you might tell that perhaps I'm not native to Canada. I am a second-generation immigrant. My parents are from Iran. I was born and raised in Canada, and that's part of what stirred my passion for the work that I did in the Eastern York region, North Durham, Ontario Health Team. So I focused on understanding newcomers' access to primary care, really trying to get at the crux of their lived experience with accessing primary care and understanding how we can modify programs to better serve their needs. So to start off, I wanted to say approximately 10%, these are 2022 statistics, so by now, about 10% of our attributed population are newcomers to the region who have immigrated to the area in the past 10 years. What was shocking for us to find is about 16% of these newcomers did not actually have a primary care provider, and that was nearly double the rate of the general population in our region. The most common languages spoken in our region are Cantonese, Mandarin, Tamil, Farsi, and Urdu. And so I chose to move forward with this engagement initiative targeting a priority population for our Ontario Health Team. We wanted to, understand newcomers' experiences with the healthcare system and also understand the challenges and barriers that they face when attempting to access care in the region. We also wanted to understand how we could modify our existing programs as an Ontario Health Team and to provide guidance to our OHT partners on how they could modify existing programs or better tailor future programs to serving the needs of newcomers to our area. And finally, because this was an engagement initiative, not really just a research study, we really wanted to be reciprocal in our information exchange. And we made sure to share information about our programs, about resources, and about how newcomers in the region can actually access primary care in the Eastern York region area. I conducted focus group discussions with 3 sets of focus groups. We aimed for representation from a diverse group of newcomers based on age, gender, the length of time that they'd been in Canada, as well as their immigration status. Were they permanent residents? Were they refugees? Were they there on work permits? We also leveraged our existing partnerships with community and health services organizations in the region, but also through these organizations, we're able to build new partnerships with settlement agencies in the region that actually supported us with newcomer recruitment, and the focus groups were actually conducted at these settlement agencies, which was wonderful for our newcomers because these are their primary points of access to the Ontario system in general. Here's just some general demographic information, but I did want to share that we have had 43 participants in our focus groups. 14 were in our Mandarin focus group, 14 were in our Cantonese focus group, and 15 were in our Farsi or Persian Iranian-speaking focus group. And you can see in the table that range of gender, age, immigration status, and length of time in Canada. We wanted to really start out, before digging into the barriers and the challenges, let's just take a step back. What are newcomers' lived experiences? What are their health needs? How do they go about navigating healthcare in the Eastern York region? And so we identified 5 top urgent health issues that are facing newcomers in our region. Vaccination was one that was identified, primarily childhood vaccinations. People are always worried about their kids. I think that's universal. Women's health issues was one that really came out strongly, specifically gynecological issues, PAPS, birth, mental health services. And when asking about mental health services, they were really interested not in pharmaceuticals, but in mental health counseling, in psychotherapy, especially in a new country where that was deemed more acceptable than some of their home countries. Chronic disease management and access to pharmaceutical drugs. What we also learned from our newcomers was that the majority of participants didn't have a primary care provider. It was not surprising, and several participants had not had any type of medical appointment or intervention since they arrived in Canada. The most common way that newcomers who did get medical attention accessed those services was through walk-in clinics, not a consistent provider that they were rostered to. We identified 7 major categories of barriers. I just wanted to point your attention to the bottom. Barriers that are especially challenging for newcomers are asterisks, the last 2. The rest are barriers that all Canadians seem to be facing today when attempting to access the healthcare system. So a lack of knowledge and information, just the complexities of trying to navigate our healthcare system. It's overwhelming for Canadians. It's 10 times more overwhelming for newcomers. Trust and communication, trust in the healthcare system, communication with providers, building that trusting relationship was seen as a big barrier. Negative experiences with the health system, especially colored newcomers' experiences, and they didn't want to access care again in the future. Lack of a primary care provider, that one's kind of straightforward. Hours of operation of primary care, so primary care operates during office hours. Newcomers especially are struggling oftentimes financially, they need to be working, and so that was a major barrier for them. Distance to appropriate care in our region. It's an urban center, but it is a bit spread out, so it's not necessarily easy to access health services and public transportation, and most newcomers didn't have cars, so this was a barrier that we found. The last 2, insurance and language of care provision, were 2 that were quite unique to newcomers. Language of care provision is sort of self-explanatory. Newcomers preferred to be able to receive care in their language of preference. Insurance in Canada, we have, in the province of Ontario, we have a provincial insurance structure, and you need to have been in the country for 3 months to be able to have access to that. We also have something called the Interim Federal Health Program, or Plan, for refugees, and that is an extremely challenging program for refugees to navigate. So they found that that was a big barrier to them knowing what was covered, what wasn't covered, and how they could access it. Based on these barriers, we also identified 4 categories of solutions or facilitators that we as a health system could implement to support newcomers with accessing care. So the first category was around navigation supports. Specific examples that came from our newcomers was an organization, a hub, something that provides me with an orientation to the Ontario or to the Canadian healthcare system. Just help me understand how to get started within the system. They wanted centralized information about health services from a trusted and reputable source. So there was a lot of word of mouth happening in the community, but people couldn't pinpoint what was accurate information and what didn't fit and what could steer them down the wrong path. They also wanted something very simple, a flowchart, a visual with not a lot of text that supported them in understanding the basic steps of how to access something like a primary care provider. They also were looking for maybe workshops or information seminars about health issues and how to access care, hosted, as an example, at a settlement agency where they access regularly, rather than making them go out to somewhere where they don't normally access anything. The second 2, language supports and care closer to home. They wanted to be able to have a centralized list of providers who could provide services in their language. And if that was not available, they really requested live translation services rather than using like a Google Translate or an app. They felt that that was not personal, as well as that there were breakdowns in communication when using an app. They weren't able to clearly communicate their symptoms. Care closer to home, they wanted mobile clinics or walk-in clinics that were more easily accessible than what exists in the region. Finally, sensitization of primary care providers to newcomer-specific needs. The examples are what the newcomers told us about, and when thinking about this, what this really meant for me was sensitizing primary care providers to be able to provide services to those newcomers in tailored ways. So communication, if you do not speak a newcomer's language, Slow down when you're talking to them. Take more time to explain things thoroughly so that they don't feel overwhelmed and lost because of those language barriers. To focus on empathy and building trusting relationships. Trust came up over and over again. And one of the important things is newcomers are often feeling lost and vulnerable in so many different ways that that first point of access to the healthcare system should be their point of safety. And so really processing that, taking that time as a primary care provider would be very meaningful for our newcomers. A quick set of lessons learned before I wrap up. I think I'm going past my time. But what was really important for us to understand is that access has both supply side and demand side determinants. So you can provide the most wonderful services, the most comprehensive set of services, but if your user cannot easily access those services, then your wonderful comprehensive services are useless. And so we really need to think about both sides of the coin when developing our programs. Certain barriers are systemic. They can be really challenging to change, and systems change takes time, while some of these things like the flow chart, very low-hanging fruit. Any Ontario Health team could develop a flow chart on how to access the team easily and quickly. So that's a solution that can be implemented within the next couple of months while we work at that larger systems change. And as a priority population for the Eastern York region and for much of the southern area of Ontario, there should be explicit consideration of newcomers' needs. This is an important population. Canada needs immigration to sustain its population, and so we need to be mindful of the needs of newcomers as we move forward in developing our primary care and acute care programs. Finally, I want to sincerely thank all the newcomers who engaged in our focus groups for their courage to speak up and share their stories. I know from lived experience and our own families, it's not easy to be that vulnerable and to share with the group. And so I want to thank them. I want to acknowledge them here. I can't name them all, but much appreciation to them. And then finally, this wouldn't have been possible without that huge list of partners and supports that I had to support with the focus groups and with analysis. Thank you for your time. Are we taking questions now or at the end?
It doesn't. Okay, no. Yes, thank you very much. We have for 2 questions, I suppose. And please wait for the microphone. Any questions, comments?
Oh.
Thanks very much. That was great. Some work we did in a high immigrant area in North Toronto about 10 years ago was very challenging because many of the people were coming from countries where primary care is not the foundation of the health system, and they didn't understand why they couldn't just go straight to specialists. Yeah. And so we actually had to go building by building to give sort of like an interactive seminar on what is primary care.
Yeah. That's such a great point, and I find that is consistent across the board with Canada. With that overarching barrier of lack of information or knowledge, it's a lack of knowledge about how the Canadian healthcare system works, because both China and Iran do not have the same type of gatekeeper model. And so that is definitely something that came up, and learning about primary care and how we work was a big gap for them. And we only had about 3 hours. This was a catalyst engagement initiative, but it was helpful for them to be able to ask us questions and get information about how that works. But it definitely requires a lot of sensitization and education.
Thank you. And second question.
Hi, thank you. That was really interesting. I'm from the UK, so I'm not familiar with your system. Do you have translators available within the healthcare system in theory, or would that be a new function?
In theory, yes, we do. And specifically within like acute care settings and hospital settings, absolutely. But primary care providers, that's never a guarantee. And so the challenge is trying to find providers who are in the community, who are taking patients, especially in Eastern York region, for example. It is a dominant Chinese, Iranian, Sri Lankan, Indian, Tamil population. And so if you have providers that are already speaking that language anyways, then being able to roster patients that way is more effective than employing external translation services.
Sorry, I think we are, our time is done now.
We
Thank
can
you
talk
very
later
much.
if you want. Thanks, everyone. Thank you.
And now I suppose we are moving to Ireland and still minority groups and identifying barriers and into integrated and equitable care. Laura Jamieson.
Thank you.
Jamieson, please.
Great. Yes, so my name badge says Ireland, but I'm actually presenting on behalf of a research group in Canada. I'm Canadian. Bruyère is based in Ottawa, and I'm representing them today on our project titled Identifying Barriers to Integrated and Equitable Care for Older Adults from Minority Groups, leading to potentially avoidable emergency department visits. So in Canada, this is not news to many people in the room, but our emergency departments are really crowded at the moment. Our staff are burning out, they're overworked, and wait times for patients to be seen are really long. In the right-hand corner of the slide, you can see a headline that was from earlier this year that some 6 million Canadians are without a family doctor. And the issue that we're seeing in primary care is often linked to the overcrowding that we're seeing in emergency departments. So what we're trying to do with this project is we're looking at potentially avoidable emergency department visits to help us understand the issues that we're facing. It's been said that emergency departments are a barometer or like a gauge of how the rest of the healthcare system is functioning. So in other words, if the emergency department is overcrowded, it's not functioning very well, it's an indicator that other parts of the healthcare system are struggling. And so that's why we're looking at these avoidable emergency department visits to try to understand where are those gaps and breakdown, essentially, in the other parts of the healthcare system. So to get some definitions just out of the way here, so emergency departments, these are designed to meet patient needs that are emergencies, requiring immediate care. In Canada, these are free for patients to access. A family doctor, on the other hand, although definitely family doctors do encounter a wide range of patient needs, including some emergency situations, really they're focused on chronic disease management. Actually, a speaker yesterday said that 80% of a family doctor's caseload in Canada is managing chronic disease. So quite a different type of service that's being provided in a family practice versus the emergency department. These are also free to patients to access in Canada. So a potentially avoidable or avoidable emergency department visit then is when a patient comes to the emergency department for a reason that may have been preventable or could be treated in a more appropriate setting, namely in family care. So I had a couple examples, but it looks like they were cut off. So some examples of preventable ED visits could be things like dehydration, prescription refill, or just not having a family doctor to begin with. So our project is an exploratory study. So today I'm not trying to give you any conclusive sort of evidence. Really the point is we're trying to just better understand the problems that I highlighted at the beginning. So how we're doing this is our first phase. We've completed some in-person surveys in 3 emergency departments, 1 in Ottawa and 2 in St. John, New Brunswick. We went directly to the emergency departments and recruited older adults 65 plus who were in the waiting room. And we asked them a series of questions. We had a survey, and a total of 92 people participated. So the survey was really trying to understand, why they were at the emergency department that day, whether or not they have a family doctor, how they're managing their health in the community, and what the barriers might be to the comprehensive care that they receive in the community. So this slide is just a snapshot of the people that we interviewed. So as you can see here, most people were English speaking. There's a near even split of men and female, or male identifying and female identifying people. And unlike the awesome presentation from Donya, the folks that we interviewed are primarily, born in Canada and living in Canada for, a significant amount of time. The most interesting, perhaps, to us was the final row, which says that almost 90% of the folks we interviewed in the emergency departments actually have a family doctor. So it makes us wonder, why are they in the ED? So telling you a bit more then about what we found. So in the dark gray is the results from Ottawa, and in the lighter gray is St. John, New Brunswick. So what this slide is showing us is that the most used healthcare services are the family doctor and the emergency department. Way more than any other service that we asked about, these are the top two services that people are using. And again, these are 65 plus patients that we're talking to. This slide is talking again about usage of healthcare services in the past 12 months. So this is an interesting slide because it's showing quite a lot of differences between the usage in St. John versus Ottawa. At this stage in the project, I can't comment on why, for example, telehealth is used more in New Brunswick, but that's definitely something that we're hoping to uncover when we do our interviews in the next phase. Another takeaway, though, or just highlighted in a different way here, that hospital emergency departments are used a lot, and these are people with family doctors. So on the next couple of slides, we've added results from the New Brunswick Health Council. They did a public health survey in 2022. And so what we're doing here is we're interested in comparing our results to the average results found by their survey in primary care. They asked really similar questions that we did in our survey, so we thought it would be interesting to compare, and indeed it did show some interesting differences. So this slide is, the question was asking, are you able to access your family doctor within 5 days? Interestingly, we can see that over half of the people in St. John that we interviewed said, yes, we're able to access our family doctor within 5 days, which is actually higher than the provincial average. But they're still in the emergency department, so we still have, obviously questions and things to understand about this particular population. This slide, I highlighted a couple of really important points for you to take away. So the first is that most people that we interviewed did agree that when they're most in need, they go to see their family doctor first, or they try to see their family doctor first. But there was, a quarter approximately of people that we interviewed that said, actually, the first place I go is the emergency department. This slide is highlighting some of the barriers that people shared with us in terms of accessing healthcare services. The biggest barrier in both Ottawa and New Brunswick, or St. John, was they're unable to leave the house. So, maybe we're talking about some homebound seniors with specific needs that may not be met in other parts of the healthcare system. The last one may look small, but I think it's important to mention that difficulties accessing internet was also something that people highlighted as a challenge. And, as Donya mentioned, the transportation issues, the infrastructure issues that really are a challenge for many people in our communities across Canada. This is another interesting one where we see a difference between the provincial results and the results that we found. So citizens who reported that they had trouble navigating the healthcare system, the provincial results from New Brunswick show a higher percentage, but our people that we asked about this, not many of them said that they had any trouble navigating the system, which tells us that maybe this group that we're talking to is well-versed in navigating the healthcare system and is maybe more health literate. Okay, so then for short answer results, these are the results from the Ontario group. We're in the process right now of analyzing the results of the short answer questions from New Brunswick, but once we do, we'll be comparing both of those and moving to the next phase. But just wanted to share some of the salient themes that we've come up with so far. The first one is that patients really want same-day care. It really came through strong in a lot of the short answer results that people would rather wait in the emergency department for, sometimes upwards of 8 hours than wait to see their family doctor. The second theme is that the emergency department is convenient. So this theme, people were talking about transportation, being able to get to the emergency department easier than getting to their family doctor, which was really interesting. Theme number 3, importantly, is speaking to, those 6 million something people in Canada who don't have a family doctor. And indeed, those people are, from what we're seeing, definitely going to the emergency department to get their needs met. So that was an important theme as well. And then lastly, these themes are related for A and for B. The first is that the family doctor actually told the person to go to the emergency department, or that the patient anticipated that the family doctor would tell them to do so. Great. So just to summarize then, and before I wrap up, we have learned so far that emergency departments and family doctors are connected for sure. Both are used way more than any other healthcare service. But the connection that's been made in the media between, not having a family doctor, and that's why emergency rooms are crowded, it's maybe not as simple as that. And there's a lot more that we need to understand about why people are ending up in the emergency department. As I mentioned, most patients that we interviewed did have a family doctor. Most people do try to go to the family doctor first, but a significant number actually go to the emergency department first. And convenience, people would rather, timely access, people would rather go to the ED and wait for a long time than see their family doctor in a few days' time. I'll wrap it up there. If anybody wants to know more about our next steps, they're really exciting, and I'm happy to take questions about that or talk to you at the end. Thank you so much for listening, and happy to take your questions. Thank you.
Thank you very much. And okay, we already have a question, right? Yep.
Thank you so much for sharing your study. That's really interesting. I was wondering if you looked at access to and capacity of family caregivers or other types of caregivers for these particular people.
Mm-hmm. That's an awesome question. In the survey, we didn't ask so much about caregivers, but we're hoping in the interviews, that's the next phase. We're actually going to be doing in-depth interviews with people to understand who else might be in their circle, or, maybe other reasons for why they've ended up in the emergency department. We know that sometimes it's about the caregiver burnout. That's why they're there, right? So absolutely, it's on our radar. Thank you for bringing that up. Definitely hoping to delve more into the complexity in the next phase. Thanks.
Thank you. That's awesome. Such an interesting presentation. It's nice to see the links. Definitely a unique population that you tackled. It's not really what we expect to hear as Canadians. The question I had was around same-day access to care at an ED. Did you find, or were you asking about the comprehensiveness of care at an ED? Because what we hear a lot from patients is also that it's not only same-day care, but if I go into the family doc, it's one issue, one appointment. I go into an ED, I can get my ultrasound, I can get all of the different things at a one-stop shop.
Exactly. Yeah, that's such a good point. Thank you. I think that's an awesome thing for us to make sure is included in the next steps. I don't think we did tackle that totally. I think right now it was a very kind of trying to be brief and overview kind of approach. And yeah, like we're hoping to understand even more about why, like if there's something that's missing in the family practice or that's not meeting their needs. That's hopefully what we're going to uncover in the next phase. Yeah. Thanks, Donya.
One more question.
Thanks very much. As a family physician, it would be wonderful for you to get the perspective of family doctors, because our patients go to Emerge even when we've offered them the same day. I've offered Saturday appointments.
Oh my goodness.
And patients have said, no, I'm going to the Emerge. Sometimes they're going to Emerge to get something that we have declined to give them, like an antibiotic. They figure the Emerge is going to give it to them. And the other reason we've heard from our family doctors in the community is they can't access CT scanning, MRIs, so they send people to the Emerge. That don't fool around. Could be, I can't get access to the care you need, so you need to go to the Emerge. We don't always say that to the patient, so be careful about taking one side of the story.
Of course. Thank you so much for sharing that. Absolutely. I really appreciate that feedback. And definitely there's a lot that we can learn from family physicians as well. And I hope that in like the co-design process that we're doing, it's definitely going to include family doctors. Absolutely. So thank you for sharing that. Okay. Thank you.
Thank you very much. And I suppose now we are staying in Canada. Jocelyn, Charles and integrated model of primary care delivery.
Hello. So you've heard a lot about Ontario Health Teams, and we're presenting from the North Toronto Ontario Health Team about neighborhood care teams, and with a focus on an integrated model of primary care delivery for unattached low-income seniors in community housing. And it's a perfect segue from our previous presentation. So before I get started into neighborhood care teams, it's important to put context around the community in which we serve. So Toronto has a population over 6 million people, which is 3 times the size of Northern Ireland. And the Community Housing Association that we support is the largest in Canada and the second largest in North America, second only to New York City. To access community housing, you have to be of low income. So we know that when to be low income, you often come with lack of informal supports, lack of family, and often living in a precarious social environment results in complex needs. So to address that, we've introduced neighborhood care teams, because we were finding there were multiple service providers coming into the buildings throughout the years to support these needs. And it was very disjointed, both for the client and for the service providers. There was lots of confusion as to who was providing care when for everybody. So what we did was we started to create a one-team approach to the model of care, bringing all the service providers together to ensure that we provide the right service in the right place at the right time, with the goal of promoting early identification and improving health outcomes. So how did we do that? Our approach is getting in there on the ground. We are physically present in the building. We are there, so we get to know the clients and they become familiar with us as well. We get to know each other. We build trust. We heard a lot earlier about the importance and value of trust and how it takes time. So what that enables us to do is if we see a client and they seem a little bit different than their usual baseline, we have the relationship to connect with them and understand what's going on, and they feel comfortable coming to us. We also support transitions, which is imperative. Study after study shows that clients fall through the cracks at the point of transition. So we're there to support them to ensure that they get to the right service as it's been identified. So the first steps we took was tenant engagement. All the buildings have tenant advisories that are involved. We worked with them and they have become an integral part of our team through co-design. We We brought in town halls into the social rooms. We wanted to create a safe space for the tenants to come and feel comfortable in their own environment. And we asked for their feedback through town halls. If they didn't feel comfortable coming to us, we went up to their floors, and we went through all the floors, door knocking with surveys and one-on-one conversations. And through their engagement, we integrated that feedback into our model. We did the same with Toronto Community Housing. They're no longer just landlords. They are part of our service team, and they have brought staff onto our team as well. And collaboratively between the tenants and Toronto Community Housing, we're building our team along with our primary care service providers. One of the goals we have, I did forget to mention earlier, that there are over 80 seniors buildings in the Toronto Community Housing Network alone. And we're hoping to scope and scale this model to ensure that we're bringing the care to the neighborhoods in which we support. One of the beauties that Toronto Community Housing has dedicated to us are clinical rooms, which we would not have gotten, clinical rooms in the buildings that we would have not gotten if we hadn't started to build that ongoing co-design relationship. So here's a list of some of the services that we've been able to introduce as a result of our model. For time, I'm not going to read them all, but I do want to highlight the physician clinic for the unattached tenants, and my colleague Jocelyn's going to be talking about that more. Some of the structures that we've built into our neighborhood care model is we've developed a regular cadence to ensure communication happens regularly. We have partner working groups monthly, we have regular business meetings, and we also have regular clinical rounds to ensure that clients are receiving timely support. And now I'm going to pass it over to Jocelyn.
I'm just going to go back one. Thanks, Naomi. So just in the right lower corner is Jane, and she's a nurse that's unbelievable. She's from my clinic, and she has been a huge mover and shaker in all of this work. And what we've really realized over time is the importance of building relationships. That these folks are not easily trusting of us, and look at us with some skepticism. So it's huge to build relationships, and I think that's what we've been able to do. So what we actually started this attachment work during the pandemic, and I know there's going to be a ton of silver linings that come out of the pandemic, and this is one of them. So we were able to have the on-site clinics, but what our nurse Jane did was she helped tenants connect to their family doctors using a tablet, so there could be video connections. And what was really great about the pandemic, I hate saying that, but there were some wonderful things that came out, is we did get physicians to be able to be paid to do virtual visits, so that was a huge enabler. We were able to, through, Naomi hasn't told you, but she works for an unbelievable community agency that does a lot of things without a lot of funding. And one of them is transportation. So we were able to get transportation to people to get to their medical appointments. We were able to sometimes attach unattached people to a family doctor locally. What we found is that and the hospital thought that many of these people were already attached because there's a family doctor's name on their chart. But when you actually talk to them, they're either not attached at all or very poorly attached. And they may not be able to get to their family doctor because of mobility issues, or the family doctor sometimes had moved farther away. So we then were able to reach out to our local community through our primary care network and try to find family doctors who are willing to accept usually less complex people or people who had less complex needs. And then we were also helping to attach people who are, say, Russian-speaking or Korean-speaking to a provider who could speak their language, because this was hugely important. And then I do provide primary care on-site for those who are unattached, and these tend to be the more vulnerable, the more complex needs people. And what's really interesting now is I started out, not many people would come. And now when I show up at the building, even if it's to do a house call on one of the tenants, I get they come up to me and start asking me questions. They start telling me about a client in another apartment that they're worried about. And when I show up for my clinic, there's actually a lineup outside the door. So it's wonderful to see this engagement. So we realized that we really do need more than just Jane and I in this building. I mean, we started with the first building, and I'm certainly not going to be the physician attached to all of these buildings. I was there to help pilot this model, and we're trying to now expand it. But we realized we do need a bigger team for sure. So we've got our neighborhood care team, and on that team, we have a pharmacist who is part of a mobile interprofessional team, wonderful for advice and guidance. We have a pharmacy that comes on site and actually helps get people onto compliance packaging. I have involved local pharmacies as well. Actually, I've personally gone out to meet some of the pharmacies in the neighborhood so I could explain to them what we were doing and get them to call me if the person's running out of medications. The on-site personal support workers actually helped by delivering medications at the right time. So we have people who are aging in place, they're getting more cognitively impaired, and so the PSW would just come and remind them to take their medications, may bring them to them, which is hugely helpful. Sprint also provides social work connections for us with the hospital and also with other community agencies, which is fantastic. As Naomi mentioned, we do have the Toronto Community Housing Service Coordinators who are immensely helpful, especially with the people that we have difficulty connecting with, people who are getting more cognitively impaired or have poor or low health literacy. We also have partnered with another agency that provides telemonitoring for no cost, which is hugely helpful as well. So there's Meals on Wheels. We have the on-site PSWs who are there many hours, most days of the week, they are our ears to the ground. So I usually check in at their office and they tell me all kinds of amazing wisdom about the tenants. And last time I went, they gave me a whole list of, can you check in on all these people? So that's great. We do have significant issues with hoarding and pest infestations, but we are working through this with our community agencies that are on our team. How can we intervene earlier, not let it get to a really challenging state where someone's health's at risk? So these are some of the things that we've been doing. As I mentioned, I do home visits, and so does Jane. And this is where you really see how are they functioning, how are they managing, is it a safety risk, is there a fire risk, do we need to get more of our team involved? And we're trying to do things in a more proactive, earlier time frame so that we don't wait till things get too bad. So some of the people who require home visits are not just mobility, they're not just apartment bound, but they may have mental health limitations. Some are afraid to leave their apartment due to maybe agoraphobia, or one of them, it's because she's quite paranoid. One of them couldn't even get out, and we had to intervene because there was such severe hoarding. So we need to, and then we also do palliative care. So in all my career of 34 years as a family doctor, and I've done thousands of home visits, I have learned an incredible amount in doing this work. It's just been a huge eye-opener, learning about how the importance of social resources, and some of these people have no connection. They have no family, they're either estranged or they immigrated to Canada. Family is in another country and they don't have any contact. The communication issue is not just language. Some of these people don't have a phone, and I'm not talking about a cell phone, I'm talking about any phone. You can't leave them messages. I drop into the building, you don't see me do this, in the evening, dropping notes under doors, reminding tenants, please go get this blood work done. And then, the whole mental health and substance use, lack of support. Now that we have our neighborhood care team, we can actually intervene and help people much earlier and not wait till they're in crisis. Some of these people have very great difficulty following a very simple plan, like you just need to go across the street to get your blood test. So sometimes Jane and I just bring the equipment and we just take the blood ourselves. So we have to make sure we understand, are they able to understand what they need and how to follow this plan? Navigating government programs, that's been a huge eye-opener for me. I had no idea. I actually have a patient with no health card and stood in the Service Ontario line up myself for an hour, try to get this person a health card, and only to be told, oh no, there's a note on her file. And I said, yeah, but he said, I can't tell you what it says for privacy reasons. I said, but I'm her family doctor. I know everything about her. He said, sorry. So now we have to go back, line up again, just to get this person a health card. So her care has been provided for free for over a year. And then you've got people with fluctuating health conditions and functioning. And so having ears on the ground, eyes on the ground with this team in the building, it's so helpful. I'll get emails throughout my day, throughout my week saying, really worried about so-and-so. Are you going to be able to come by the building this week? Or could Jane come by? We just need to check in on this person. It's just hugely helpful. So we've realized the importance of early recognition, partnering with local pharmacies, also our whole team, using the telemedicine, the telemonitoring is very, very helpful. But it's great to just have increased eyes. Our tenant advisors will often stop us in the hall and say, I'm really worried about so-and-so. They haven't come out of their apartment in several days. So this early recognition, and we're teaching our whole team what questions to ask to understand people in difficulty. And then increasing our connections with all of the providers, and being able to integrate. We have a mobile interprofessional team who's been able to work with us and really sort of get, when people have needs, we're not going to have them wait in line to get an occupational therapy assessment. We're just going to ask the home care, give us an occupational therapist for a half day, and we can have them see all these people and get that all done. So we want to do them more efficiently. And then continued work with our hospital to identify unattached people who live in these buildings so that we can be proactive in their discharge. And then really looking at our chronic disease pathways, they look different for this population. You can't just take a cookie cutter pathway and plunk it down in a low health literacy, low social resource population. How do we build that? And then really anticipating change and being able to be proactive together for the most vulnerable. So it's been hugely rewarding work, some of the most rewarding work I've ever done. The patients, or I shouldn't say patients, the tenants are so grateful. And I love to bring my medical students and family medicine residents, and the praise we get is just unbelievable. They just can't, they keep saying, I can't believe you come here. I can't believe we actually get this service right here. And I had a Russian-speaking medical student who absolutely loved this work. And when I brought him the Russian tenants, it was like a fire hose of information. And he said, can I come back for the rest of my medical training to work here with you in this building, because it's so meaningful to me. And so we were there on International Women's Day. And he said, you realize that's a really important day in Russia, and that these people are just praising you as a woman for coming to the building to see them. So wonderful work, wonderful team, and really making a difference.
Thank you. Thank you very much. I think we have to move on to our next presentation. We are out of time now. So I think we are moving to, was it Australia? Caroline Nicholson, and using the implementation research logic model. I'm very curious to hear, what is it?
Logic in evaluation, does that ring true? I like to say I'm Caroline from Australia. Whilst it is Australia, there's quite a strong Canadian theme going through this, so it's quite interesting that even though we've changed continents, we've actually got some of the same problems and the same technology as an answer to that. So I'd like to first of all recognise the other authors in this work, particularly Jenny Job, who is the Director of Research in our research centre, but also Maria Donald and Claire Jackson. This work wouldn't happen without them. I just happen to be here presenting it. So this is really just to explain the implementation research logic model, which we're going to call from now on because it's too long, and looking at how we use that to assess a digital solution to improving timely access to specialist care from GPs. So most people know what implementation science is, but the crux of it is that, first of all, the aim is to look at identifying barriers and enablers across the multiple contexts which we all work, and that from there to develop and apply implementation strategies, ultimately to increase the uptake of evidence-based clinical innovations into practice. Now, we also know that there are a plethora of different models, frameworks, theories, whatever, within implementation research. Some of these have their background in evaluation, but are more now commonly put under the implementation science umbrella. Whilst each of these do different things, it's sometimes difficult to know which to use and when, and how to incorporate them into a sort of a coherent assessment of implementation. So we use something that was designed by Smith and Rafferty. It's actually not a model in itself. It's actually a pipeline logic approach. And the real key thing here is that it puts together various theories and frameworks. It's to assess implementation. So very quickly, I'm not going into all of them, but within this particular model, the determinants framework on your left, that's really to look at the barriers and facilitators of the innovation. And we have things like the consolidated framework for implementation research, which is the one we use, but there's the theoretical domains framework, there's Paris, there's other ones within that group of determining the determinants, but we use the CIFR. There's the process models, which specify the strategies used for implementation, and in this case, it's with the ERIC model. And then on the right, the evaluation frameworks, which actually look at the aspects of implementation that can be received to determine the success of implementation, so what the outcomes are. And there's things like the re-aim, the proctor, the proceed, but we're using the proctor. And in the middle, you put the actual practice change itself. So what was the problem that we had, or that everyone has, I think it's not just us, but with increasing life expectancy, chronic disease, all the things that we're all hearing about, lack of workforce, we know that there's a problem within our outpatients. Our wait times are increasing year on year. We know that patients' health deteriorates whilst waiting for specialist advice or input. The likelihood of avoidable hospital attendances increases, and particularly for us, and I know for a lot of other people living in very big countries with a lot of space, and that's Australia, that access issues are particularly hard for rural remote patients to do with distance, cost, and just the time that it takes to travel. So we looked at an e-consult model. It's an internationally best practice model that's mainly started in Canada, and we're working with the University of Ontario. They're our research partners, Claire Liddy and Erin Keeley, but they use it across North America and the US the US UCSF use it, Mayo, as I say, Ontario e-consult. I think every state and province, I understand, in Canada has some type of e-consult, although it uses different processes and technology, but they all have one. But our thing was, well, if it works there, given we've got similar, you've got a bigger, but Canada has a bigger population, but we have similar issues with time and distance and lack of workforce, all those things. How can we take that and implement it into the Australian setting? So we thought, well, let's go Queensland. So we started, we're collaborating with our primary health networks in Western Queensland, which is the pink bit, the green bit, which is Northern Queensland, and then you probably can't see it very well. But there's this little tiny pink bit here, which is Brisbane South. So we had an urban primary health network, and we have two very big geographical areas. So just as a comparison, I think the country of Ireland fits 25 times into Queensland, so it's quite big. What was I going to say? Right, so we have the primary health networks. We also have Mater Health Services, which is our health service. We have the Queensland Government. We have the Australian Digital Health Agency. The Royal Australian College of General Practice and our Ontario friends and partners in the research, the Ontario eConsult. So what is it? For those that don't know, I know many of you do, but basically it utilises, in our case, from the GP or the family physician. We haven't done nurse practitioners yet, it's on the cards. We use existing software from the general practices that auto-populates a request for advice. It's not a referral. The clinical governance and the care stays with the GP. It's auto-generated and sent via secure messaging to a specialist with a specific question. There has to be a question. It's not like, here's the request for advice, what do you think? It has to be very specific around what they want to know. The specialist replies within 3 business days, and there's one of 3 outcomes. They answer the question, they ask for more information, or they request a face-to-face. And or an appointment, which could be via video, via telehealth, or face-to-face. It's accessed by acute care, general practice. We have a Royal Flying Doctor Service, which covers the state, and Aboriginally controlled medical centres. So this is the as we had it sort of, and we went through this process with all of our partners to look at what the determinants are, what is it we're trying to do, what are the strategies, and what outcomes are we looking for. And so with outcomes, you look at the implementation outcomes, and then there's effectiveness, cost, and there's patient outcomes as well. So this is sort of how we applied it, and it really helped, particularly a lot of the other stakeholders, see what we're actually trying to achieve on a page, and everyone's signing up for. So what we did a proof of concept in 1 urban practice. We expanded it to 4 rural remote practices, which was an Indigenous practice, 2 Royal Flying Doctors, and a private practice in Western Queensland. And we started with access to general medicine because we felt that it kind of covers a lot of medicine rather than choosing one specific one. And that's what we did. Oh, sorry. So as of the 1st of April this year, we've got 22 GPs, 45 practices, doing 392 patients via this. We started with general medicine. We went to 3 others, endocrinology, dermatology, and cardiology, and from the 1st of March, we've extended it to other medical specialties, not surgical. It's a mixed method evaluation. We're looking at administrative data from the eConsultant platform. Got GP collection as a closeout survey, which is fantastic, and the GPs have been great. Specialist data, we're doing qualitative interviews, and we also did a costing analysis. So what did we find? This is very much in line with what the Ontario eConsultant found. From GP request to advice, for the eConsultant, it's on average 1.7 days. For the patient, so when the patient's been seen with the GP and they send it off, we ask the GP to make an appointment within 2 weeks for the patient to come back and get the feedback from the advice. The GPs are seeing them within 14 to 15 days. It takes about between 10 and 13 minutes for GPs to actually fill in the request for advice like a normal referral. And the specialist time, it's taking about 22 minutes. The really key thing here is the bit in the circle. This bit here. So 15% of patients have had to go on for a face-to-face. 85% of people who would otherwise have been a category 1 to 3, which is putting onto a waiting list in our case, don't have to go on to have an outpatient appointment. And you can see what they're sent for, and the categories that I mentioned are at the bottom here. The majority of them are category 2 semi-urgent, but we still do have some which do fit into the category of the most urgent. You can see here that we had 1 specialty to start with, we added 2 additional ones, and we had an uptake, and then we've increased it again to 8. And this is what the advice is. If you really need to scale it so that it's at front of mind of practices. What happens is if you're just doing it for general medicine, you might see 1 or 2 of those maybe whenever, a year, every 6 months. But if you're doing it for 3 or 4, but if you're doing it for 8, or our goal is to do it for 20, it becomes part of more routine practice. So we're scaling it slowly, but we're getting there. So the closeout survey, 84% of cases, GPs rated the advice as excellent. They were either to confirm the routine action or got new advice about what they should do. And there was a small percent, 3%, who didn't feel that it was actually helpful in that case. The qualitative feedback, I'm not going to read all of these out, but for GPs in these particularly vast areas, they can refer, in our case, to very different regional centres. You might have cardiology in Cairns and neuro in Townsville, and this way you just have to send it to one place and you get one answer. So they found that really helpful. And sometimes the patients can't or don't want to travel to get care. We have a lot of First Nations people in those rural remote areas, and they want to stay on country and actually get care on country. So this is really becomes an equity issue for that population as well. But generally, the benefits have been that the practice GPs feel that it fills a service gap, certainly improves access. They love the response within 3 days. They get a response and they can get back to the patient, and then everyone feels that they can move on rather than waiting an undetermined amount of time. And in the past, GPs have often tried to contact specialists if it's not just a referral, but they just want to know something, but you end up playing this phone tag. And even with video conference and teleconference, if you've ever worked, most of you have, but within primary care, trying to link the two, a specialist and a GP, is you just don't have time, and it's not a very efficient way of doing it. And as I said, patients have often had to wait very long times and travel very great distances. And it's not just the patients, it's the carers, it's the families. It's time away from work, time away from the rest of the family. It's a really limiting point of fact when they have to travel. And patients do appreciate this as a continuity of care with their primary care provider. They really feel very well supported. Again, I'm not going to read them, but basically the process has been very easy to use. It's just like you would send a referral, except it's called e-consult request for advice. It auto-generates, it sends, it comes straight back into the practice software from a general practice point of view. They felt that there's a lot of support in place, and we've developed that. We find that there are themes coming through around various specialties, so we target our training for practices, and that's the whole practice, the nurses and the allied health around that. And they just keep asking for more specialties, more and more every time we do it, which is great. There are barriers, not particularly for private practice, private general practices. We have some practices in Queensland who there is no general practice from a private. The business model makes it very hard to be sustainable because of the population and all sorts of issues. So we have the acute care services actually provide the general practice. It's a whole other story. But their software and their technology as we found out, very outdated. Their focus and their work isn't generally general practice. So it's been a bit of a learning curve to try to bring them up. Their practice software was, version 101 when the rest is on 13. And the secure messaging, they can receive information, but they couldn't send it. So it was very focused on the acute side, even though it was meant to be general practice. So there's been a lot of learnings that we've had. And we're also in Australia waiting for secure messaging standards, and we are working with the Digital Health Agency about how we can facilitate that, but it's a work in progress. From the specialist point of view, they feel that it's an organised way of working. Before, people would phone up and ask the questions, and if they did give advice, there was no documentation, often other than people just writing in charts, and not everyone did that, not the specialists. And there's a funding stream, which there was, you couldn't bill before because it was just a quick phone conversation. So there is actually a funding source, particularly for the GPs, because they have the patient with them. The focus really, they feel, is really focused on the GP and the patient and that continuity of care. And we really have, the specialists have really embraced it, which is fantastic. We do need to work on the funding source because, that whilst there is some there, whether it's adequate, that's a part of our current work. And it really the specialists feel that they are seeing the people that they need to see in hospital, not some of these people who just can be collegiately sort of working with, but general practice can actually be provided with care there. We have done a costing analysis, the reference is there, and I could talk about it for a long time, but I won't. But basically, we just looked at the outpatient process. We didn't actually take into account the travel costs, the time away from work, and all the other costs, and that's part of our ongoing work. But simply just looking at a process of outpatients and managing a referral versus an e-consult, and there was a 61% efficiency gain. So it's not only, and that's an efficiency gain to the hospital. That doesn't go to general practice, but there is an efficiency gain to the hospital side of things. So what we're trying to work out is how we translate that with all the other costs and how we might then redirect some funding to actually support this into primary care. So the learnings are, and these are sort of under the sort of the outcomes, the proctor sort of side of things, that it grows with more specialties. The effectiveness, it reduces time to specialist input, which we know has a positive impact on patient outcomes. It does provide continuity of care for patients. We haven't had any adverse events, so there is a safety issue. You know, if people said, well, what if? But we haven't had that yet, and I have to say the Canadians haven't either. The determinants, it does improve access. We are looking at additional specialties. The digital infrastructure, I'm a clinician by background, and I've become some kind of expert in secure messaging, not. But it's been a learning curve. I realise that while we've got all this digital, sometimes it's not actually fit for purpose, particularly when you're trying to work across different organisations and different professions. We know that the efficiency gain is there. Whilst it's for the hospital, we need to look at how we can actually translate that into primary care and support more care this way. And certainly for us, it really does improve access, particularly for those people who don't want to travel. You know, people managing vast properties or their First Nations, they really don't, they can't afford to have that amount of time away from where they live. So where are we going? We are looking at the statewide model and looking at the costing. As I said, we haven't taken into account, we have a patient transport travel subsidy in Queensland. It was 85 million in, I think, 22-23. That's gone up 21% since the previous year, so we're probably nearer 100 million now. And, you know, a lot of time and money is spent on this, so we're trying to sort of look at how we can redirect some of that. We want to look at the reverse e-consultant, or TREC as it's called. So these are people on the waiting list. How can we actually look at those people and offer e-consult as an option to GPs and say, you know, would the patient like this and would you like this? And we're also looking at some of the ED avoidance issues around e-consult. If it's a question that can be asked by a nurse practitioner or a GP, is it a way of trying to avoid those people who don't need to go to ED? Thank you.
Thank you, and I'm sorry, I think we don't have time for discussion, and I suggest we are stealing about 5 to 7 minutes from the lunch break, so that we have a reasonable time for the 2 remaining presentations. So, Susan Joyce and Holly Opara, right?
Awesome, thank you, and good afternoon, everyone. So my name is Holly Opara, and I'm here today with Dr. Susan Joyce, and we're going to be sharing our approach to using integrated health hubs and care teams to improve access to primary care for our North Toronto community. So obviously this work isn't just done by 2 people. We do want to acknowledge the lovely, wonderful project team that has helped move us to where we are today, and so you'll just see a name of a few of the folks who are involved in this work. So I know it seems like we have a very Ontario-heavy crowd today, or Canadian crowd, so we've heard a little bit about this. But in 2019, the Ontario government did introduce Ontario health teams to kind of put the patient, family, and caregiver at the center of their healthcare. And so OHTs really are groups of providers who have voluntarily come together to improve access and coordination of services for patients and their families and caregivers. And at maturity, we don't know when that will be, and I'm sure we're on the long journey towards that, but it said that OHTs will be funded through an integrated funding envelope. So a little bit about the North Toronto Ontario Health Team. So we are one of 58 OHTs in Ontario, serving 200,000 folks within kind of the North Toronto, Greater Toronto area. A list, or on this slide here, you can see a list of our partners. So we have 8 partner organizations, from primary care to acute care settings to home and community care, and our community support agencies, which include mental health supports. And then, of course, through engagement with our primary care network and our patients, families, and caregivers who are so key to co-designing the initiatives that we bring to our communities. So a little bit about the community that we serve. So compared to kind of the city of Toronto and the province, North Toronto is considered to be more affluent, have higher levels of socioeconomic status, and lower levels of health service utilization. But after conducting a kind of population level analysis, there are pockets and neighborhoods where we do see various barriers to accessing care. So on the right-hand side, you'll see kind of our 2 high priority neighborhoods, our Mount Pleasant West and Angle Mount Lawrence, and that's where the majority of our services as an OHT are focused at this time. So you can see different kind of attachment rates, higher health service utilization, more folks who are beyond kind of the lower income measure, as well as higher levels of visible minorities and seniors living alone. I'll also draw your attention to a key stat around population growth. And so we're seeing in North Toronto extensive population growth, especially in the Mount Pleasant West community. So a little bit about the primary care context in Ontario and in North Toronto specifically. So like many in the region, and as Laura kind of highlighted, North Toronto is facing dwindling access to primary care. In Ontario, our primary care providers kind of have a decentralized model, and so they're kind of independent business owners, similar to like our local convenience stores. But the difference there is that we haven't seen an increase in revenue or an inability to increase revenue for our primary care providers that helps to offset the high operating costs that come with practicing in North Toronto. We also are very under-teamed, and so oftentimes the primary care providers are practicing in solo practices, leaving them to try and figure out and navigate the system that they work in. A recent study in Ontario did show that over 40% of our primary care providers are considering retirement in the next 5 years. So we see family physicians leaving in droves, but then we also see kind of our new graduates and new residency folks not choosing family medicine as their specialty to practice in. And so we don't have that kind of pipeline of next generation talent to help meet the ever-increasing demand. And so what does that mean? We're seeing 1 in 4, or 25% of residents or individuals presenting to our local emergency department being unattached to primary care. And so Laura kind of alluded to some of the issues that has with capacity and flow through our acute system and into transitions, but it also might lead to kind of not appropriate care in the wrong setting, and potentially they could be better serviced elsewhere. From a North Toronto population perspective, I mentioned we're seeing extensive population growth. We currently have 80,000 residents within our North Toronto region who don't have access to a primary care provider. Also previously mentioned, we are significantly under-teamed, so patients aren't receiving kind of that interdisciplinary care compared to the rest of Toronto. So we are at 7%, and Toronto is at 22%. With family physicians' offices kind of being knocked down for the replacement of condominiums to support population growth, we're really in kind of a capacity crunch where we see ever-decreasing supply of primary care providers and an ever-increasing population. And so through some data analysis that we did, it was determined that we need 62 full-time equivalent primary care providers to help support the primary care demand that we are seeing. That number is shocking to us, but not surprising. And it's kind of what we heard as well with our community engagement that we've done. So North Toronto has a plan, and our OHG has a plan, and so I'm going to pass it over to Susan now to walk you through our approach to ensuring that patients have access to primary care.
Thank you so much, Holly. This crisis is actually in our national newspaper today, so it's very, very topical. So our North Toronto OHT has a strategy to support our local patients and our population, and it is our aim to deliver team-based care to all our residents soon. We have 3 prongs to our approach, and you've just heard from Jocelyn and Naomi about one prong, which is the neighbourhood care team. We also have a small spoke delivering interprofessional care services to a small number of primary care practices. But what I wanted to share with you now is about our health hubs, which we are planning to deliver attach 20,000 patients to primary care, team-based primary care in the next couple of years. The hub will house team-based primary care, and it'll decrease the costs and incent new family doctors to join these high-needs areas. The hub will be a collaborative community model of care. It'll be locally co-designed with the neighbourhoods, and it'll serve the unattached and the complex patients in those local high-needs areas. It will be a one-stop shop and a no-wrong-door approach. The team members will vary based on the local needs of each neighbourhood, and we will have community ambassadors, social workers, nurses, physios, as I said, depending on local needs. To address the retention challenge that Holly has beautifully described, we will have developed collaborations and affiliations with the local family doctors in the surrounding areas, and through that we will be creating stronger community connections. And those family doctors' practices, currently 7% of patients only being able to access team-based care at the moment, those family doctors' practices will be able to access team-based care at the hub while maintaining the care of their patients themselves. The family doctors will also be able to access back office supports, which are a huge benefit to our family doctors with digital supports because the burden of running a practice is huge in Ontario at the moment. At the moment, we have a very robust working plan in motion to deliver these health hubs, and we have 4 work streams, as you can see here on the diagram. The first is the vision and advocacy stream, and as I said, this was in the paper today, so our advocacy efforts to bring our needs to all levels of government are coming through. The public is understanding what we're doing, and we're bringing this strategic clarity that was mentioned earlier in the conference. We are working on the care model and operations of the hubs, and the focus will be oversight of the business model. This will be a new business model. At the moment, we don't have a funding model for team-based care in Ontario, which we so badly need. So we need to bring this new model to our donors and potential funders so we can support team-based care. The focus of the care model will be the development of this business model, as I mentioned. We have looked carefully and in detail into our space requirements. We believe we need 15,000 square feet for each of the hubs, and we have been looking at various sites and discussing with developers, and we've done site visits to other health hubs in Ontario, which are slightly different in their models, but we have looked at their architecture and makeup. For the care model and operations, I should have said each hub the running costs will be between 3 and 7 million annually for each hub, we estimate. The diagram on the right, partnerships and engagement, is a huge ongoing area for us at the moment. We're engaging with our patients and family caregivers. We're engaging with our primary care practitioners and building a strong primary care network. And we're engaging with other community partners like pharmacy and lab to see if we can really get this model off the ground. So that's a huge piece for us right now. As you can see, these health hubs will benefit patients, providers, and the system as a whole. Obviously, patients will have a co-designed care close to home, right care in the right place. They'll have better continuity of care. It'll be very much a relationship-based model. They'll have expanded access to team-based, to after-hours care. For the providers, the team-based care, as I said, is a huge piece for them to support them in their work and allow every provider to work to their full scope across the team. The back office supports will be a huge help, especially the digital supports, things like we just heard from Queensland. And we'll be fostering a strong learning environment for all team members, and this will be a new model of learning where the team members will all learn together in one location rather than in silos as we've done, which will, we hope, bring great integration for the future. The system, of course, will benefit through retention of our family physicians who are planning on retirement, and we will create a model of care that is attractive to our young doctors because they want to work in team-based models. They've been trained in team-based models, so we hope to retain them in these high-needs areas through creating this model. We've developed the cross-sectional partnerships have been huge with our hospital partners and our community partners, as we've just heard with our community organisation, the neighbourhood care team. And these models will help us feel stronger in the future if we have to face adversity again like the pandemic, and it gives hope to the members of the teams as well as the incoming younger people. So what have we learned from all this work? We don't have the hubs yet, but we've learned a lot already. We've learned about how we need to showcase the crisis and bring this strategic clarity to everybody. We've learned how to use a population health management approach with very localized data, which has enabled us to pinpoint where we need to build these hubs. We've learned the importance of listening to all our members everywhere on the ground, in the hospitals, in the community organizations, so that we can develop a model that really works for everyone. We've learned the importance of advocating so that we can really communicate the urgency and the impact of the proposed plan and its alignment to provincial and regional priorities. Collaborating, of course, is key to all of this, and the strength of our partnerships has been growing all the time, and this augurs well for future planning, spreading and scaling of this model. We've also learned that it's really just important to get going, to just start with a minimally viable option so that we can really address the root causes of our current challenge and journey on and make better access for all our patients. So thank you for listening today. Are there any questions? Do we have a few minutes?
Yes, thank you. I think we have time for two questions, maybe.
Hi, thank you. That was really interesting. I wondered if social needs are kind of a part of your remit and whether social isolation or loneliness sort of features in your plans.
Sorry, I didn't quite hear the question.
Social needs and whether there's whether it's health-based or whether you'd be perhaps considering social isolation or loneliness.
Are we considering the social needs? Absolutely, yes, yes. The social needs will be addressed based on local needs, and we hope that the home and community care services, the social services, will also be embedded into this model as we move on, absolutely.
Okay, thank you. Short question. Who is belonging to these teams? What professions?
Sorry, I didn't hear that. What professions? The professions will be based on the local needs. So there will be, for sure, nurses, social workers, physicians, OTs, physios, but the complement will be unique to each of the hubs. We plan there will be needing 5 hubs over the next few years, but we will have community ambassadors to connect us with the local people and find out exactly, so that we'll have our ear to the ground as we move forward, building what people need and want.
Yes, thank you.
Maybe, can I add one thing to that too? To Jocelyn's point around the emergency departments being able to access kind of all those services all at once, we are working with other health system partners to kind of bring a convenient co-located shop of services, so DI, lab, social settlement services, things that the communities need and interact with, so that it is kind of a one-stop shop for all their health and social services there.
Okay, thank you. And
thank
now,
you.
Last but not least, Nasser Khalil, and still on Canada, and Sarah Kyoni.
Yeah, let's go back. So good afternoon, everyone, and I know we are the last ones, and I was thinking when I was trying to build this presentation that I'm presenting in an international setting, and I want to give a little bit brief about the Canadian system, but it looks like you know more than what I know. So just to go very quick on this is the Canadian system that you know. So I will talk about the system in Ontario, which is publicly funded and administered by the Ministry of Health in Ontario, and provide the healthcare, universal healthcare coverage for primary care, for hospitals, for diagnostic imaging, labs, and some other coverage to population. Medication is not covered, so it's variable because it will be covered for some specific population partially. So let's go directly to the challenges that we are facing in Ontario. And the main 3 challenges that we are facing in Ontario are the capacity, the aging population, and the effective integration. And those are why we are here. So I'm working now on a project called Lower Limb Preservation Program. So in this Lower Limb Preservation Program, we want to reduce the number of amputations for lower limbs. So before going to that, I want to walk you through the other 2 challenges about the aging population in Ontario and in Canada. And as you see that in Canada, as our last census for the population, we have around 37 million population, and around 40% of them living in Ontario. And in Ontario, we have 30% of the population, they are 70 years and older. So it looks like we have a good number of seniors in Ontario. And for these seniors, sometimes we have 70% of the seniors, they have 2 or more chronic conditions, and will add some pressure on the system. And if we talk about that the system and the high system users, in Ontario, we have 5% of the Ontarians, they account for 2/3 of the expenditure in Ontario. And if this 5% increase by time, so will add more challenge to the system and for the sustainability of funding and those kind of things. And in the coming 20 years, we are expecting the number of seniors will be, as you see, 65 years and older will be double, and the centenarians will be triple, and the number of 85 and older will be quadruple. So we have to do something to work on that. So the last challenge that we want to talk about is the system integration. That's why those conferences are built, to build an integration to support the healthcare systems and provide the seamless transition between care settings to the patients. So everybody knows that our system in Ontario, and like any other areas of the world, it's siloed and it's provider-centric, and we don't have a true integration between providers and other care settings, and that's because we have a very strong regulations and privacy and risk that prevents that the flow of information between providers and other care settings. So let's talk about the system, the project that we are working on right now, which is lower limb preservation program. And why we do this? We do this because the amputation rates in Ontario considered one of the highest among the world. Even we have higher amputation rates than the UK and some other countries, as you see. So to talk about the risks of amputations, the main 2 risks of amputations is the diabetes mellitus and the peripheral vascular disease. And we have 1.5 million people, they have diabetes in Ontario. This is more than 10% of the population. And also we have 15 to 20% of the people who age 70 years and older, they have risk of developing peripheral vascular disease. So in the past 5 years, we identified more than 300,000 of population, 300,000 people, they have high risk of amputation. And we do currently 1,200 major amputations in Ontario, which with a cost of 70,000 per amputation. So we think that effective integration and effective screening and identifying those patients at risk of amputation will improve those rates moving forward. So we expect to reduce 20% of the major amputations in the coming period. That will save around 240 lower limbs in the coming period, and this may save $16.8 million in the dollars. So our scope, so we aim to reduce the amputations, and we want to, based on our values, to work with the population that they need more focus on that. So we approach this project with an equity lens. So the patient population that we are working with is the people who are deprived from housing, and the people who are identified as indigenous groups, and the people who face barriers to care, so those unattached to primary care, or they have some challenges with attaching to primary care. So the objectives is to build an integrated care pathway and to implement an integration tool, which we use it as there is an application called SWIFT we use within this project, that we use it as a wound management application that people can take photos for the wound, it determine the wound progress, to determine the dimension of the wound, the depth, how the wound is progressing, and this can be accessible through different providers within the region. So those are the lists of the regional partners that we are work with them to integrate them through the SWIFT application, through the program. And also just a little bit about SWIFT. It's just an application that you can download in your mobile. And we got an approval from the Privacy and Risk at London Health Science and St. Joe's Healthcare to work with SWIFT, but it's as a it's not interfacing with the Cerner or with the healthcare system for now, but in future maybe if we prove the success of this work. And we want to use it as an integration tool that we can collect even the patient information, patient experience and providers experience data through among the different community partners. Now I will leave it to Sarah Gurney to walk you through the integrated care pathway.
Good afternoon, everyone. So I'm Sarah Gurney, and my background is as a wound care specialist. So I'm a nurse specialized in wound ostomy and continence care. And I've been working on this project because obviously wound care is a big part of saving lower limbs. And so I'm going to walk you through a little bit of how we developed our clinical pathway and who was involved in that work and where we're at right now. So initially, as Nasser mentioned, the patient population of focus is really taken from an equity lens. So I know we talked a lot about seniors and a lot of our seniors being unattached. That is future work for us. Currently, we're focused on those that are vulnerably housed or experiencing homelessness, as well as our Indigenous populations. The rate of amputation among Indigenous people in our area is 7 times greater than the general population. And so, so those are kind of our equity-deserving populations that we're focused on right now. So in developing the clinical pathway, the engagement really happened with stakeholders as well as patients that are experiencing those kind of walks of life, and the stakeholders being the healthcare providers that engage with them regularly. We started by looking at sort of the current system and how do people access care in our region, and why is it not working well, and then looking at how can we start to improve some of that. So the barriers for the patient populations that we're focusing on right now are really accessing the care. When you don't have a home and you don't have a phone and you don't have a way for somebody to get a hold of you and connect you to a clinic that's actually really far away from where you can walk to with your cart of belongings, it doesn't work well. And so what we were finding is that the patients that we were hearing about from our stakeholders are people that aren't going to clinics, because the referral system in Ontario right now through home care is that you fax a referral or you phone it in, and someone has to then connect with that patient over the phone or in person to get that referral initiated, get consent, add them to the service, make a referral to a provider, and it's not a dedicated provider, so it might be miles away. So it just wasn't working well. And so we wanted to look at how can we remove barriers, and many barriers, but the first being getting access to the care. And so we looked at having a centralized way of attaching patients to the service. So we worked with our providers around some education around how can you get access to wound care services in our region without having to go through this cumbersome system and having patients fall through the cracks in the system. And by doing that, we did work with home and community care initially to establish that central intake process of a live phone call with the patient from any setting to be able to do that intake in the moment and get them connected with the right care. We've had some challenges in that space with the health system transformation that's happening in Ontario right now, and home care in particular. But we do still have that approach right now, and we have this kind of low barrier access to a clinic. When looking at our clinical pathway, I recognize that this lower limb preservation work is humongous, right? It's like there's so much upstream work to do, but there's also so much downstream work that has to happen to make this successful. When we were looking at what we wanted to target, we had to make this something we could bite off and chew within the timelines that we were given from Ontario Health, and really decided to focus on the highest risk patients, which are those that already have a wound. So 80% of amputations are preceded by a diabetic foot ulcer. We know that from the evidence. So we really wanted to have a place where we could care for patients that have an active wound. Part of the reason for that is when you look at screening and risk stratification and prevention, if you screen someone and they've got an active wound or they have something they need, and then there's no system in place to actually provide that, you very quickly lose traction in the ability to continue that screening and risk stratification. So we wanted to have a system in place that once we screen, we've got some care available, and then work our way backwards into that prevention space and those kinds of things. So that's kind of the approach we took. We did develop the clinical pathway to be a spoke, hub, and node model. So working with all of our partners, we have a nursing clinic set up as kind of our spoke. So that's your frontline care. We are getting access to wound care specialty services. It's nursing and wound care specialists providing that service. The hub is a primary care network, so primary care diabetes support program through St. Joe's, which is one of our acute care settings. They have some outpatient support with some physicians that provide expertise in wound management as well as meeting the primary care needs of patients. And then the node is our acute care centers where we know we need access to vascular support, orthopedics, and those kinds of specialty services for patients to try to prevent amputations, as well as kind of manage if there is the need for those minor amputations, and hopefully not, but major amputations as well. So it was just a collaborative approach with all of those stakeholders at the table, coming together and working through that process of developing the flow for the patient from beginning through to the end of the journey. And we were able to start sort of implementation of that in October of last year, and this is kind of where we're at now. So we've had about 50 patients screened through the program in our mainstream pathway, which is those that are vulnerably housed but do not identify as First Nation, Inuit, Métis, or urban Indigenous. And we've had 17 screened to date in our Indigenous pathway. Our Indigenous work is largely supported by our Indigenous community, so we're there to support that initiative, but really it's designed by them and implemented by them in the way that is culturally appropriate for them. And we have provided education to 28 different sites for that identification of patients, so finding the patients that need to be referred into the services. I naively believed at the beginning that this would be the emergency department. I thought, well, everybody goes to emerge when they have a wound, right? But for this patient population we're looking at, that's really not true. Many of them only go there as a last resort. They don't trust the system. They're not seeking care in that setting. So we've had to kind of seek out where are the places that we can engage with and work with. Our goal is really to bring the care to the patients rather than having the patients come to us. So we're working with our partners around where can we deliver that wound care. And we do have the Canadian Mental Health Association as well as some other shelters and different things engaging with us to provide a space right now where we can deliver the care to the patients in a safe way. Yeah, is there anything? One thing I want to say about the people that have been served to date, the 50 patients particularly, is just that when we look at very early metrics around this, the one significant thing is that all of these patients have not been receiving care effectively through the traditional system. So it's pretty exciting to see that we've been able to reduce the barriers in getting patients access to care that they can then follow through on. They were patients that had either received a referral to home and community care and then no one was able to get a hold of them, so their file was closed and no one followed up and they continued to have wounds. Or they were patients that had been referred and they got a hold of them, got them connected to a clinic, but they couldn't access it routinely and regularly within the system, so they weren't receiving adequate care. So just, I think this is kind of the last piece, is really just to wrap up around what have been our wins, our challenges, and our lessons learned in this process. It has been a bit of an uphill battle through the last year in trying to design and implement this. Lots of challenges with particularly the system transformation that's happening in Ontario right now within the healthcare system. The home and community care is really a big partner in this work. A lot of wound care happens in the community setting. And with the system transformation that's happening, there's been very limited ability to make local changes to the way services are delivered. So it's a fee-for-service model in Ontario within home and community care. It's high barrier for patients that can't access easily. We wanted to remove those challenges, and so we've been able to do that through this project, but trying to get that transitioned into sustainability and operations is going to take time because there's just not the ability right now to engage home and community care in that way. So it's still, fee for service for them. There's appointment booking times. There's things that are really barriers to patients that that aren't able to access those services in that way right now. And that's what we're hoping to demonstrate through this project, is the success that we can have in that, and then be able to translate that back to home and community care to be able to assume this model moving forward, or our OHT partners as that transition to OHTs happens. What have been some of our other challenges? Yeah, the home and community care transition. And then some of our wins so far have really been that we've designed this integrated care pathway, we've engaged with patients and stakeholders and been able to really develop an entire model that goes right from identification of patient through to acute care and back again, wrapped around with that digital application that Nasser was sharing that's really AI enabled, and we take pictures of wounds and we measure, et cetera. And then that communication follows the patient to whatever setting they go to, so everybody can see what's happening and provide input into that. We do now have a dedicated provider, home care provider with expertise in wound management and access to the primary care diabetes support program, again, with physicians and nurse practitioners supporting us from a primary care perspective that have that added expertise in wound care. We're learning that technology plays an important role in improving our healthcare system and integration, and that it's important that we stick to our core values of equity, even though it might be harder and take longer. So that's been one of our big challenges, is that this is a very vulnerable group, and it does take longer to engage in the work that we're trying to do, even though we have tight timelines. And so we're just kind of staying the course with that, and recognizing that we might have to adjust our thinking around what we're doing. So we've been strictly providing care, or initially our scope was around diabetic foot ulcers, but when we look at engaging with partners and finding spaces to work and different things, recognizing that in that homeless or precariously housed population, that diabetes isn't the only reason they have wounds. And so by limiting to that, we're actually excluding patients. And so we had to sort of adjust our thinking around that piece as well. And then just sustainability considerations. We're just still looking at how can we sustain this in the long term, and work with our partners in the system and the current transition that's happening to try to make sure that this good work doesn't stop. And that's it.